I want you to look at your elbow right now. Just take a look.
Okay.
If you saw a patch of red, scaly skin there, what's your first thought? Your gut reaction.
Oh, easy. I'd think, dry skin.
Right. Or, I need to switch my laundry detergent. Maybe you think you leaned on something weird at the coffee shop?
That is the reaction 99% of us would have. It's annoying, it's cosmetic, it's a surface-level problem.
You put some lotion on it.
You put some lotion on it and you move on with your life.
Right. And that is exactly where we get it wrong. That is the trap. Today, we are tearing down that assumption.
We really are.
We are looking at a stack of research that completely flips the script on what we think we know about skin. We're working primarily from the Clinical Practice Guidelines for the Management of Psoriasis, the 2024 second edition from the Ministry of Health, Malaysia.
It sounds incredibly dry, doesn't it?
I know. Clinical Practice Guidelines. Sounds like the title of a document you'd use to cure insomnia, not a disease. I was ready for a nap.
Like something you'd use to prop up a wobbly table.
Exactly. But when you actually crack this thing open, it reads less like a rule book and more like a detective story.
Yeah.
A story about the human immune system gone rogue.
That's it.
Because the headline here isn't about skin. It's about a systemic fire that just happens to be venting through the skin.
That is a perfect way to frame it. These guidelines aren't just a list of creams and ointments. They represent a fundamental shift in how medicine views inflammation. The central metaphor used in the field, and it's heavily implied in this text, is the iceberg.
The iceberg. Okay, set the scene for me. What are we talking about?
Think of the skin plaques, the red, itchy, scaly patches, as just the tip of the iceberg.
Okay.
That's the 10% you can see above the water. It's clinically significant, sure. It hurts, it can bleed, it's visible to other people.
The part that's annoying you.
The part that's annoying you, exactly. But the massive chunk of ice lurking underneath the water, the 90% you don't see, that is systemic inflammation. That is immune dysregulation. And if we only treat the tip of the iceberg, if we ignore what's happening underwater, we are putting the patient in serious long-term danger.
So our mission today is to map that entire iceberg. We aren't just talking about lotions. We're going to find out how a patch on your skin is actually biologically connected to your heart health, to your joints, your mental state, and even your genetics.
And we are going to climb the entire ladder of treatments, which has, it's changed drastically in just the last decade.
How so?
We've gone from essentially, putting tar on people to using what I can only describe as biological guided missiles.
I love a good guided missile metaphor. But before we get to the sci-fi stuff, we have to understand the beast itself. Let's look at section 1 of this deep dive, the nature of the beast. The text defines psoriasis as an immune-mediated systemic inflammatory disease.
A real mouthful.
It is. So let's unpack that. Immune-mediated. Does that mean my immune system is weak?
No, actually, it's the exact opposite. Your immune system isn't weak. It's overactive. It's hypervigilant. It's paranoid.
Paranoid.
To understand this, we have to look at the core mechanism described in the guidelines. It's called the IL-23-TH17 pathway.
Okay, let's pause on that alphabet soup. IL-23-TH17. I feel like I need a PhD just to say that. What is that in plain English?
Okay, think of your immune system like a modern military defense network. You have the generals and you have the soldiers.
Right.
In a healthy body, the general only gives the order to attack when there is a clear and present enemy, like a virus, a bacteria, a fungus.
See a germ, kill the germ. Simple.
Well, exactly. But in psoriasis, there is a fundamental communication breakdown. You have a general in your system. It's a protein messenger called interleukin-23, or IL-23 for short.
Okay, General IL-23.
And this general has gone rogue. He is screaming, attack, attack, through a megaphone 24/7. There's no off switch.
But there's no enemy. There's no germ to kill.
There is no enemy. It's a false alarm. But the soldiers, specifically a type of T cell called a Th17 cell, are very, very obedient.
They just follow orders.
They hear the general screaming, so they wake up, they multiply, and they deploy to the front lines.
And the front line is my skin.
Precisely. These Th17 soldiers rush to the skin and they release their own chemical weapons. The main one is called IL-17.
Another number.
Another number. And this is where the physical damage happens. IL-17 is like napalm for the skin cells. It hits the keratinocytes, your basic skin cells, and gives them a frantic, panicked order. You need to reproduce now, fast.
How fast are we talking? Because I know skin sheds naturally. I mean, I see dust in my house. That's dead skin.
It is. And normally a skin cell takes a very leisurely journey. It takes about 28 to 30 days to be born at the bottom layer of your epidermis, to mature, travel up to the surface, and then flake off.
A slow, graceful exit.
A very orderly process.
Yeah.
In psoriasis, that entire cycle is compressed into 3 to 4 days.
3 to 4 days. That's, what, 10 times faster than normal?
It's an insane rate of production, and the body just can't handle it. The cells can't shed fast enough to keep up with the new ones being pushed from below.
So what happens?
They pile up, they stack on top of each other like a multi-car pileup on the highway. That stack of immature, poorly formed skin cells is the plaque, or the silvery scale that you see.
And the redness underneath that plaque.
That's the inflammation. The body is pumping blood to the area to feed this frenzied army of cells and all the immune activity, so the blood vessels dilate. They get wider. That's why it's red and often warm to the touch.
That is a terrifying image, but it makes total sense. Now, the text mentions phenotypes, which I assume is just doctor speak for what it looks like.
Exactly. Different presentations.
And it says plaque psoriasis is the main one, right?
Correct. About 80 to 90% of all cases are plaque psoriasis. The text describes these as symmetrical, well-defined, thick, edematous, scaly plaques.
Okay, let's break that down. Symmetrical is a key clue here.
A huge clue. If you have it on your left elbow, you will very, very often have a similar patch on your right elbow, or both knees.
And well-defined.
It means you can usually draw a line around it. It has a clear border where the psoriasis stops and the normal skin begins. It's not like a vague, blotchy rash.
Okay, and it loves the extensor surfaces, so knees, elbows, the parts you extend, but it also loves the scalp.
The lower back, what we call the sacral area, and the gluteal fold.
The gluteal fold, the butt crack?
The laughs indeed. Medical terms always sound more dignified, don't they? But yes, it can hide there and be quite distressing for patients.
There were 2 signs mentioned in the text that I found really visual. One was the auspices sign. It sounds like a secret handshake or something.
It's a classic diagnostic clue. If a doctor were to pick off one of those silvery scales, which, by the way, you should never do, it's not good for you.
Don't pick that at.
But if a professional did, you would see these tiny pinpoint bleeding spots underneath. That is auspices sign.
Why does it bleed like that?
Because the blood vessels in the skin haven't just dilated, they've actually grown upward into the plaque. They're elongated, they're tortuous, and they're very fragile and close to the surface.
So when you peel the scale, you're essentially just ripping the roof off those tiny, fragile vessels.
That's a perfect description. It's a sign of what's happening on a microscopic level.
Ouch. Okay, don't pick the scales. The other one was the Koebner phenomenon, which sounds like a rule. Don't poke the bear.
That is exactly what it is. The Koebner phenomenon, or Koebnerization, refers to the development of new psoriasis lesions at sites of skin injury.
Any injury.
Any injury. So a patient might scratch a bug bite or get a bad sunburn or have a surgical incision, and then weeks later, a new perfect line of psoriasis forms right along that scar.
So the trauma calls the immune system to the area to fix the cut.
Right, the normal repair crew shows up.
And because the system's already hyperactive and paranoid, it just decides to set up a new camp there.
That's it. The repair crew arrives, but that rogue General IL-23 is there too, screaming, "Attack!" And suddenly you have a new plaque where there was none before.
Incredible. Now, while plaque is the most common, the text lists a few others. Guttate. That sounds like gutter.
It actually comes from the Latin word gutta for drop, like a drop of water. Guttate psoriasis looks like small, red, raindrop-shaped spots scattered all over the trunk and limbs. It's visually very distinct from the big, thick plaques, and it has a very specific trigger.
I remember this. Strep throat, right?
Yes, specifically the bacteria Streptococcus pyogenes. We see this very often in children or young adults. They get a nasty sore throat, and then 2 or 3 weeks later, they break out in these spots all over their body.
Why? What's the connection?
It's a classic example of something called molecular mimicry. The immune system gears up to attack the strep bacteria, but certain proteins on the bacteria look a little bit like some proteins in our own skin.
So the immune system gets confused.
It gets confused. It clears the strep, but then it keeps attacking the skin because it thinks it's still fighting the infection.
And then there are the really scary sounding ones, erythrodermic and pustular.
These are severe and they can be life-threatening. Erythrodermic psoriasis isn't just a patch. It involves widespread redness erythema covering almost the entire body surface.
So the guideline says more than 90%.
More than 90%. So you're just one giant red inflamed lesion.
What does that do to you?
Well, your skin is your thermostat. It's your barrier. When it's that inflamed, you lose the ability to regulate your body temperature. You can get hypothermia, you lose fluids and proteins through the skin. It's a medical emergency that requires hospitalization.
And pustular.
Pustular psoriasis is also very severe. It involves white pustules, which are little blisters of non-infectious pus surrounded by red skin. This can also be widespread and cause systemic symptoms like fever.
Let's move to something that I think people forget to check. Nails. The text says 40 to 50% of patients have nail involvement. I mean, I would just think I had brittle nails.
It is so common and so often overlooked. And the nail changes can be a huge clue, especially if the skin disease is subtle.
So what are we looking for?
The damage can happen in two places. The nail matrix, which is the little factory under your cuticle where the nail is made, or the nail bed, which is the skin underneath the nail plate.
What happens if the matrix is affected?
If the matrix is affected by inflammation, you get pitting.
Like little dents.
Exactly. It looks like someone took a tiny ice pick and made divots in the nail plate. Or you can get crumbling, where the nail just disintegrates and falls apart.
And the nail bed signs. What happens there?
The most famous is the oil drop sign, sometimes called the salmon patch. It literally looks like a drop of oil or a spot of salmon-colored pink trapped under the nail. It's a very specific yellowish-red discoloration.
Okay, I can picture that.
You can also get splinter hemorrhages, which look like tiny black or red lines running vertically, like you got a wood splinter under your nail. These are all crucial diagnostic clues. Sometimes a patient has very little skin involvement, but their nails tell the whole story.
So we know what it looks like in all its various forms. Let's talk about who gets it. The text mentions a bimodal onset.
That's just fancy talk for two peaks. The disease tends to show up for the first time at two specific periods in life.
Which are?
The first peak is in early adulthood, usually between age 30 and 39. The second peak is later, between age 60 and 69.
Which brings us perfectly to the million-dollar question. Section 2 of our dive, nature versus nurture. Could I do this to myself, or was I just doomed from birth?
It is rarely, if ever, just one or the other. It is a collision. We call it multifactorial. You need the seed, the genetics, and you need the right soil, the environmental triggers.
Let's talk about the seed first. Is there a psoriasis gene, a single gene that causes it?
It's not just one. It's highly polygenic. The guidelines mention that researchers have now identified over 100 distinct genetic loci, so places on your DNA that are linked to psoriasis risk.
100. Wow.
But there is one big boss. One major player.
The PSORS1 locus.
Right, the psoriasis susceptibility 1 locus on chromosome 6. And within that, a specific gene variant called HLA-CW6.
HLA-CW6. Sounds like a droid from Star Wars.
Laughs, it really does. But if you carry this specific allele, your risk isn't just slightly higher. The text says it accounts for about 35 to 50% of the heritability of the disease.
So half the genetic risk is in this one spot.
Pretty much. If you have this gene, your immune system is essentially primed. It's on a hair trend, just waiting for an excuse to misbehave.
But here's the thing that always confuses me. I know people whose parents have psoriasis, but they don't have it. How does that work?
That's the mystery of penetrance. Just having the gene isn't enough. You have the gun and it's loaded. That's your genetics, but something have to come along and pull the trigger.
And the trigger is the nurture side of things.
The environmental factors. Exactly.
The text lists a whole lineup of suspects for pulling that trigger.
Yeah.
And the biggest villain in this whole document, by a country mile, seems to be smoking.
Smoking is catastrophic for psoriasis, and the guidelines are very specific here. It's not just a vague, smoking is bad for you. There is a clear dose-response relationship.
Meaning the more you smoke, the worse it is.
Exactly. The text notes that smoking more than 25 cigarettes a day, or having a history of smoking for more than 30 years, drastically increases your risk of developing psoriasis.
But it gets worse, right? It's not just about starting it.
It's not. Nicotine itself actually binds to receptors on the immune cells, the dendritic cells and T cells, and it fuels that inflammatory fire. So if you are a current smoker and you already have psoriasis, the treatments just don't work as well.
So you're literally fighting against your own medicine.
You're pouring gasoline on the fire with one hand and trying to put it out with a fire extinguisher with the other. It's a huge motivation to quit.
Okay, what about weight? The text mentions obesity quite a bit, especially in the Malaysian context, where obesity rates are unfortunately quite high.
Obesity is a major, major driver. We used to think that fat tissue, adipose tissue, was just inert energy storage, just blubber.
Right.
But we now know that biologically, adipose tissue is an active endocrine organ. It is alive and it's communicating.
It's an organ, like your
Yeah.
liver or your kidney.
In a way, yes. And it secretes hormones and chemical messengers called cytokines. Specifically, it secretes pro-inflammatory cytokines, the very same messengers that drive psoriasis, like TNF-alpha.
So having excess weight literally puts your body in a state of chronic low-grade inflammation 24/7.
That's the perfect summary. The source data shows a clear correlation. As your BMI and your waist circumference go up, so does your risk of psoriasis. And just as importantly, the reverse is true. Losing weight can actually help clear the skin.
And alcohol, same
Yeah.
story.
Similar story. High consumption is a risk factor. The text defines high consumption as more than 224 grams per week. It increases the risk of onset, and like smoking, it can make treatment more difficult.
How so?
Well, partly because of the inflammatory effects, but also, as we'll see later, some of the best psoriasis drugs are hard on the liver. If you're drinking heavily, you simply can't take those drugs.
Stress was another big one. The text describes it as a vicious cycle. Stress triggers psoriasis. Psoriasis causes stress.
It is one of the most common triggers patients report. The guidelines quote a range of 27 to 71% of patients who say stress is a major trigger for their flares.
Why? What's the biology there?
The nervous system and the skin are intimately connected. They actually come from the same embryonic tissue layer when we develop. When you're stressed, your nerves release chemicals called neuropeptides that can directly stimulate the immune cells in the skin to kick off that inflammatory cascade.
So we have the setup.
Yeah.
You have the genes, you get stressed out, maybe you smoke, you catch a strep throat infection, and boom, the iceberg forms.
The perfect storm.
But let's go back to that iceberg analogy. This is the crucial part, section 3. The hidden danger. Why should we worry about this if we could just cover the spots with long sleeves? Why is this a systemic disease?
This is the so what of the entire deep dive. This is why the Ministry of Health Malaysia put out a 100-plus page document on it. The inflammation is not staying in the skin.
It's leaking out.
Those cytokines we talked about, the IL-17, the TNF-alpha, they are circulating in your blood. They are washing over every single organ in your body, day in and day out.
The stats in the Malaysian registry regarding this were startling. Obesity was at 62.9% among psoriasis patients, hypertension at 28.5%, diabetes at 19.2%.
Those numbers are incredibly high, and here is the really scary part. Psoriasis is an independent risk factor for cardiovascular disease.
Okay, independent risk factor. Explain what that means.
It means that even if you control for all the other traditional risk factors, so even if you aren't a smoker, even if you aren't overweight, even if you don't have high blood pressure, just having severe psoriasis by itself increases your risk of having a heart attack or a stroke.
Wow.
The inflammation in your skin is mirrored by inflammation in the walls of your blood vessels. This accelerates atherosclerosis, the hardening and narrowing of the arteries.
That is genuinely terrifying. You think you have a skin rash, and suddenly your doctor's talking to you about a heart attack.
It is concerning, but I want to flip it to be empowering.
How so?
Because it means that by treating the psoriasis aggressively, we aren't just making you look better or feel less itchy. We are potentially protecting your heart. We are reducing that systemic inflammatory burden and lowering your cardiovascular risk.
That's a huge paradigm shift.
It is.
The text also links it to mental health, and not just, I'm sad because I have a rash.
No, it's much deeper and more biological than that. The psychological burden is immense. Depression, anxiety, and even suicidality are significantly higher in psoriasis patients.
Is that just from the stigma?
That's a huge part of it. The itch, the pain, the bleeding, the social stigma of people staring at you or being afraid to touch you. But there is also emerging evidence that the inflammatory cytokines themselves can cross the blood-brain barrier and affect brain chemistry, directly contributing to mood disorders.
So it's a biological link, not just an emotional reaction.
We believe so, yes.
There were a couple of other associations in there that surprised me. Inflammatory bowel disease?
Crohn's disease and ulcerative colitis, they share similar genetic pathways and inflammatory mechanisms with psoriasis. They're like immunological cousins. In fact, your doctor really needs to know your gut health before prescribing certain psoriasis treatments because some can help Crohn's, but some can actually, paradoxically, make it flare up.
And the liver. You mentioned that before.
Non-alcoholic fatty liver disease, or NAFLD. Psoriasis patients have about a twofold increased risk. It's likely linked to the whole picture of metabolic syndrome and obesity, but again, the systemic inflammation is a contributing factor.
Okay, so we've established this is serious. It's the whole body. How do doctors measure how serious a case is? Section 4 is about assessment tools. It seems like it looks kind of bad, isn't a scientific enough measurement.
We need objective numbers to track progress and to decide on treatment. The most basic one is the BSA, the body surface area.
How do you measure that? You're not wrapping the patient in grid paper, are you?
We can use something called the rule of nines for large areas, but the simplest tool, and one you can use yourself, is your own hand. The patient's hand palm and fingers together represents roughly 1% of their total body surface area.
That's a handy trick. Pun intended.
It is. So if you can cover all your plaques with about 10 of your handprints, you have 10% BSA involvement.
And is 10% the magic cutoff?
Generally, yes. Mild psoriasis is defined as a BSA of less than or equal to 10%. Moderate to severe is anything greater than 10%. But, and this is a huge catch, the guidelines are very, very clear on this. There's another number that matters just as much.
The DLQI.
The DLQI, the Dermatology Life Quality Index. It's a simple 10-question questionnaire. It asks things like, over the last week, how much has your skin affected your choice of clothes? Or has it impacted your relationships? Or has it stopped you from working or studying?
Why does that matter as much as the surface area?
Okay, imagine you have psoriasis just on the soles of your feet. It might only be 1% of your body surface area, so technically it's mild by BSA.
Right.
But if it cracks and bleeds every time you take a step, you can't walk. You can't stand, you can't work, your quality of life is destroyed.
It's severely impacting you even if it's small.
Exactly. The guidelines allow us to classify that patient as having severe psoriasis based on the DLQI score, even with a low BSA. This gives us the green light to treat them aggressively.
That makes so much sense. A small patch on your back's annoying. A small patch on your genitals or your hands can be debilitating.
Precisely. And then for clinical trials and for really close specialist monitoring, we use the PSI, the Psoriasis Area and Severity Index.
What's that?
It's a much more complex calculation where the doctor scores the redness, the thickness, and the scaling of the plaques in 4 different body regions. It's the gold standard for measuring response to treatment.
And the goalposts for that treatment are moving, aren't they? The text talks a lot about treat to target.
This is a key concept in modern medicine. We don't just treat and hope for the best anymore. We set a specific, measurable target. The traditional target in psoriasis was something called PSI 75.
Meaning a 75% improvement from where you started.
Exactly. But with the newer, more powerful drugs we have now, the super goal, the new standard, is becoming PSI 90 or even PSI 100.
PSI 100 means zero psoriasis, completely gone.
Completely clear skin. That used to be a fantasy, an impossible dream. Now it is a realistic, achievable goal for many, many patients.
PSI 100. That sounds incredible. So let's talk about how we get there. Section 5. The first line of defense. If I walk into a doctor's office with a new diagnosis of mild psoriasis, I assume I'm not getting the guided missiles just yet.
No, you're not. You're going to start with topicals, creams, foams, and ointments. And the unsung hero here, according to the text, is the humble moisturizer, an emollient.
Just plain old moisturizer, like from the drugstore.
Never, ever underestimate it. Psoriatic skin has a broken, defective barrier. It can't hold water in, it dries out, it cracks, it fissures. Emollients restore that barrier, they reduce the itch, and they actually help the medicated creams penetrate better. It's the absolute foundation of care.
But the heavy lifter is the steroids, I assume.
Topical corticosteroids. They are the workhorse of topical therapy. They reduce inflammation, they stop the itch, they constrict those dilated blood vessels, but you have to use them correctly. The guidelines are strict. Potency matters.
Because the skin thickness varies all over your body, right?
Exactly. You cannot put a super potent steroid on the thin, delicate skin of the face or the groin. You'll cause thinning or atrophy or stretch marks. But for a thick, stubborn plaque on your back or your heel, you need something strong to punch through that scale.
And there's a measurement for this too, the fingertip unit. I love these little practical units of measurement.
It's so useful. 1 FTU is the amount of cream you can squeeze from a standard tube nozzle onto the pad of your index finger, from the tip to the first crease.
Okay.
And that amount should be enough to cover an area of skin equal to 2 of your palms. This prevents patients from underdosing, which does nothing, or overdosing, which can cause side effects.
Now, a lot of people get scared of steroids. Steroid phobia is a real thing. Is there a good non-steroidal alternative?
There is. Vitamin D analogs. Specifically, a drug called calcipotriol.
Vitamin D, like the sun vitamin.
It's a synthetic version. It binds to the vitamin D receptors in your skin. But it doesn't work by suppressing the immune system broadly. It works by inhibiting that rapid cell proliferation we talked about. It directly tells the skin cells, slow down, you don't need to divide yet.
And it's safer for long-term use.
Much safer for long-term use than strong steroids. You don't get the same skin thinning.
The text mentions combining them. Is that the best approach?
That is the most effective topical strategy. A combination product that has both a steroid, like betamethasone, and a vitamin D analog. The steroid gives you a quick anti-inflammatory hit, and the vitamin D provides the longer-term control. The source highlights some of the new aerosol foam formulations as being particularly effective.
What about the old school stuff? I saw tar in the outline. That sounds medieval.
Coal tar. It's ancient. We've been using it for over a century. It smells like a freshly paved road, and it will stain your clothes and your bedsheet.
Does it work?
It does work. It's anti-inflammatory, and it slows cell growth. The text says it's still a valid option, especially for difficult scalp psoriasis, and despite the scary tar name, the cancer risk from therapeutic use is considered very low.
And salicylic acid. I know that from my acne face wash.
It's a keratolytic. Kerato refers to keratin, or skin, and ilytic means to cut or dissolve.
So it dissolves skin.
It eats away the thick, dead scales. In psoriasis, we often use it in combination with other drugs to strip away the plaque's armor so that the steroid or the vitamin D can actually reach the living skin underneath and do its job.
Okay, so that's the creams.
Yeah.
But let's be real. If you have plaques all over your back or you cover 20% of your body, rubbing cream on yourself becomes a full-time job. It's sticky, it's messy, it takes forever. When do we step up?
That's when we move to Section 6, phototherapy. Using light as medicine.
Light therapy. Now, I have to ask the obvious question. Can I just go to a tanning salon?
No, absolutely, unequivocally not. The guidelines are very firm on this. Commercial tanning beds emit a broad spectrum of ultraviolet light, mostly UVA.
And that's bad.
UVA penetrates deep into the skin, it damages your collagen, it ages you, and it significantly increases your risk of melanoma and other skin cancers, all without doing very much to actually help the psoriasis. It's all risk, very little reward.
So what are doctors using? It's a special kind of light.
We use NB-UVB, narrowband UVB.
Narrowband. Like a laser, almost.
Sort of. It uses a very specific filtered wavelength of light, right around 311 to 313 nanometers. Scientists figured out that this specific wavelength is the sweet spot.
Sweet spot for what?
It effectively suppresses the overactive immune cells in the skin, but it avoids most of the more harmful wavelengths that cause burning and long-term cancer risk. It's much safer than the old broadband UVB.
How often do you have to go for that?
It's a big commitment. The guidelines recommend 2 to 3 times a week for several months. You go to the clinic or hospital, you stand in a light booth that looks kind of like a shower stall lined with glowing fluorescent tubes.
And you get zapped for a few minutes.
You get zapped for a few seconds or minutes. It's highly effective. Many patients clear up completely, but the logistics can be really tough. You have to take time off work, drive to the clinic, get undressed, get zapped, get dressed, drive back 3 times a week.
I saw there's an older version called PUV.
PUVA stands for psoralen plus UVA. It's an older, more potent method. You take a pill called psoralen, which makes your skin incredibly sensitive to light-like, vampire-level sensitive.
Okay.
And then about an hour later, you get exposed to UVA light. It's very effective for very thick, stubborn plaques, but it has a significant safety ceiling.
A ceiling. What do you mean?
The guidelines have a specific warning. If you've had more than 200 PUVA treatments in your lifetime, your risk of developing squamous cell carcinoma, a type of skin cancer, goes up significantly. So we really try to stick to the safer narrowband UVB these days.
Okay, creams didn't work. Light didn't work. Or maybe the disease is just too aggressive from the start. Now we're talking about swallowing pills or taking injections. Section 7. Conventional systemic therapy.
This is where we start suppressing the immune system from the inside out. And the gold standard here for decades has been a drug called methotrexate, or MTX.
Methotrexate, I've heard of that. Isn't that a chemotherapy drug? That sounds really scary.
That word does scare a lot of people. And yes, at very, very high doses, it is used to treat certain cancers like leukemia. But for psoriasis, we use tiny doses, maybe 10 to 25 milligrams once a week.
Just once a week?
Once a week. At this low dose, it doesn't act as a chemo agent. It acts as an anti-inflammatory and an immunomodulator. It's cheap, it's effective, and doctors have been using it for 50 years. We know it well, but it has baggage.
Let's talk about the baggage, the folic acid rule.
Right. Methotrexate works by interfering with how your body processes folate, which is a B vitamin that's crucial for cell division. To prevent side effects like mouth ulcers or nausea, you have to take a folic acid supplement.
But not on the same day.
But, and this is the dance you have to learn, you cannot take the folic acid on the same day as the methotrexate
Why not?
because it would compete with the drug and basically cancel out the therapeutic benefit. So the standard routine is you take your methotrexate on Monday and you take your folic acid on every other day of the week except Monday.
And the guidelines are very clear. No alcohol.
Not a drop ideally. Methotrexate is processed by the liver and can cause liver toxicity over time. The guidelines strongly advise against any significant alcohol consumption while on it. It also suppresses the bone marrow, so we have to do regular blood tests to monitor everything.
What about acitretin? That's related to vitamin A, right?
Yes, it's an oral retinoid. It's not an immunosuppressant. It works by normalizing skin cell growth. It's especially good for very thick, scaly psoriasis on the palms and soles.
But it has a massive warning label for women,
A huge one. It is highly teratogenic,
meaning it causes severe birth defects.
devastating birth defects. And unlike other drugs that wash out of your system in a few days or weeks, acitretin gets stored in your body's fat cells. It can stay in the body for a very, very long time.
How long?
The guidelines state that a woman of childbearing potential must not get pregnant for at least 2 to 3 years after stopping the drug.
Wow. 3 years.
Yeah.
That basically takes it off the table as an option for any young woman who might even be thinking about having a family someday.
It's a complete deal breaker for many, yes. Then you have the last of the conventionals, cyclosporine.
You called this the fire extinguisher.
That's a good name for it. It works incredibly fast and it's very powerful. If someone is having a terrible widespread flare or has that dangerous erythrodermic psoriasis, cyclosporine can calm it all down in just a few weeks.
What's the catch?
The catch is that it's toxic to the kidneys and it raises your blood pressure. It is not a long-term solution. The guidelines recommend it shouldn't be used for more than 2 years continuously and ideally much less. It's a bridge to get you out of a crisis, not a destination to live at.
Okay, so those are the older drugs. Effective, but they come with a lot of side effects and monitoring. Now we enter the modern era. Section 8, biological therapies. These are the game changers you mentioned?
These have completely revolutionized the treatment of psoriasis. It is not an exaggeration to say this is the biggest breakthrough in our field in the last 50 years.
How are they so different from something like methotrexate?
Methotrexate is like carpet bombing. It suppresses the whole immune system a little bit, non-specifically. Biologics are the laser-guided missiles we talked about. They are monoclonal antibodies. These are proteins that are engineered in a lab that are designed to find and neutralize one specific target in that whole inflammatory pathway.
So they hunt down General IL-23 or the soldier's weapon IL-17 specifically.
Exactly. They ignore the rest of your immune system. They find that one rogue cytokine, they grab onto it, and they take it out of commission. It's incredibly precise.
The text lists a few different categories. Let's break them down. The first generation.
The first ones were the anti-TNF alphas, drugs like adalimumab, etanercept, and infliximab. They target a cytokine called tumor necrosis factor. They work well, they're still used a lot, and they're particularly good for patients who also have psoriatic arthritis.
But then we got even more specific.
Then we moved further down the pathway to the anti-IL-17s, drugs like secukinumab and ixekizumab.
Why are these special? What's their claim to fame?
Speed. We call them the speedsters because IL-17 is the final step. It's the soldier actually firing the napalm at the skin cell. When you block it, you can see results incredibly fast. We have patients achieving PSI 90 or PSI 100 in just a matter of weeks.
Are there any specific downsides to blocking IL-17?
Well, it turns out that IL-17 is actually quite important for helping our bodies fight off fungal infections. So when you block it, you have a slightly higher risk of getting candida infections, like oral thrush or yeast infections. It's usually mild and treatable, but it's something to be aware of.
And the newest group on the block, the anti-IL-23s.
Guselkumab, risankizumab. These drugs go all the way back up to the top and target the general IL-23. They stop the whole cascade from even starting.
What's their advantage?
They are highly effective, and what's really remarkable is the durability of the response and the convenience. Because you're targeting the master switch, the effects last a very long time. You might only need an injection once every 2 or even 3 months.
The text mentions super responders. This is a really hopeful part of the document for me.
Yes. This is based on the concept of the window of opportunity. The data is beginning to suggest that if we treat patients with these highly effective biologics early, specifically within the first 2 years of their diagnosis, they respond much, much better.
Better how?
They're more likely to achieve complete lasting clearance. The old way of thinking was fail the cheap stuff first, suffer for a few years, and then you earn the right to get the expensive stuff.
That paradigm is shifting.
It is. The new research implies that if you wait too long, the immune system learns the disease. It creates a persistent memory of the inflammation. If we can strike hard and early with the big guns, we might be able to prevent that memory from forming. We might be able to effectively reset the system.
But safety is still a concern, isn't it? These are still suppressing a part of the immune system.
They are, and we have to be careful. The biggest check we do before starting any biologic is screening for tuberculosis or TB.
Why TB?
This is especially important in places like Malaysia and Southeast Asia where TB is more common. Many people can have latent dormant TB in their lungs without knowing it. Your immune system, particularly TNF-alpha, is what keeps it walled off. If you block that, the TB can wake up and cause a severe active infection. So screening is mandatory.
And cost. I imagine these laser missiles aren't cheap.
They are extremely expensive. That's why the guidelines spend a lot of time discussing biosimilars.
Biosimilars, are those just generic versions?
Essentially, yes. But because biologics are large, complex proteins grown in living cells, you can't make an exact carbon copy like you can with a simple chemical like aspirin. Instead, you create something that is highly similar, with no clinically meaningful differences in safety or effectiveness.
And the guidelines say they're okay to use.
The guidelines state clearly that the evidence shows biosimilars are just as effective and just as safe as the original originator drugs. This is a key development for making these life-changing treatments more affordable and accessible to more people.
There's a new category that sort of sits between the old pills and the new injections. Section 9, the new kids on the block, oral small molecules.
Right. Some patients are just terrified of needles. They absolutely will not do injections. But maybe methotrexate is too toxic for them or they can't take it. For them, we now have great oral options.
Like a Primost. It's a PDE4 inhibitor.
Exactly. It works inside the immune cells to block an enzyme and dial down the production of inflammatory signals. It's a pill, taken twice a day.
How does it compare to the biologics?
It's not as powerful, you won't see as many PSI 100s, but it's very, very safe. It doesn't require the same intense liver monitoring or TB screening. It's a really good option for moderate disease or for difficult areas like the scalp or palms and soles.
And deucravacitinib, that's a mouthful.
It's a TYK2 inhibitor. It's a newer oral pill, and in the head-to-head trials mentioned in the source material, it significantly outperformed apremilast. It's proving to be a very strong oral option for patients with moderate to severe disease who want to avoid injections.
Let's pivot to section 10. We touched on this earlier, but we need to go deeper. Psoriatic arthritis, or PSA.
This is the major comorbidity that we worry about. The guidelines say about 20% of psoriasis patients will develop it, and the tragedy is it's often missed for years until permanent, irreversible joint damage is done.
So what are the red flags? The text mentions sausage digits.
The medical term is dactylitis. Your entire finger, or your entire toe, swells up so it looks like a little sausage. That is a classic hallmark sign of psoriatic arthritis. It's very different from the knuckle swelling you see in rheumatoid arthritis.
And another strange word, enthesitis.
Enthesitis is inflammation and pain, where tendons and ligaments attach to the bone. The classic spots are the back of the heel, where the Achilles tendon is, or the sole of the foot. If a psoriasis patient comes to me complaining of persistent heel pain, my alarm bells for PSA go off immediately.
And morning stiffness, how is that different from just, feeling creaky when you wake up?
It's the duration and the pattern. This is inflammatory stiffness. It lasts for more than 30 minutes, sometimes an hour or more. And crucially, it gets better with movement and activity. Mechanical arthritis or wear and tear usually gets worse when you move.
The guidelines emphasize using screening tools, things like PEST and EARP.
They're just simple questionnaires. Have you ever had a swollen finger or toe? Do your nails have pits or holes? The key message for you listening is this. If you have psoriasis and your joints hurt, tell your dermatologist immediately. Don't just assume it's getting old.
Because if you catch it early.
If we catch it early, we can use drugs like methotrexate or the biologics to stop the inflammation and prevent the joint destruction. Once the joint is destroyed, you can't grow a new one.
Let's move to section 11, special populations. Pregnancy. This seems incredibly tricky because, as we said, some of these drugs cause terrible birth defects.
It requires very careful planning, ideally preconception counseling. The good news is that for many women, psoriasis actually improves during pregnancy.
Why is that?
It's nature's way of suppressing the immune system slightly to prevent the mother's body from rejecting the baby. But the flip side is that postpartum flares after the baby is born are very, very common.
So what's safe to use during pregnancy?
Moisturizers and low to moderate potency steroids are generally fine. UVB phototherapy is also considered safe, but methotrexate and acitretin are absolutely forbidden. They are known to terminate pregnancies or cause severe defects.
What about the biologics? Can you stay on those?
It depends. For most of them, we weigh the risks and benefits. But there is one standout, a TNF inhibitor called certolizumab.
What's special about it?
The molecule is structured in a way, it lacks a specific fragment, that prevents it from actively crossing the placenta to the baby. So very little drug actually gets to the fetus. It's considered the safest biologic to use during pregnancy and breastfeeding.
What about kids? It must be heartbreaking to see a child with psoriasis.
It is, and it's becoming more common. Of course, we start gentle
Yeah.
topicals, maybe MBUVB light therapy if they're old enough. But if it's severe, we have to treat it. We don't want kids growing up with the pain, the stigma, and the risk of arthritis.
What are the options for them?
Methotrexate is considered the first-line systemic drug for children. And now, several of the biologics, like etanercept, ustekinumab, and secukinumab, are officially approved for pediatric use if other treatments fail.
Finally, let's talk about Section 12, lifestyle and alternative medicine. This is what everyone wants to know. Can I just eat my way out of this? Can I go gluten-free and cure myself?
Patients love to ask about diet.
Yep.
And the guidelines are very evidence-based and level-headed here. Let's start with a gluten.
Okay.
Unless you have a confirmed diagnosis of celiac disease, which is slightly more common in psoriasis patients, but still rare overall, there is no good evidence that a gluten-free diet will help your skin.
So save your money on the expensive gluten-free bread unless you have celiac. What does work?
Weight loss. This is the single strongest piece of lifestyle evidence we have. If you are overweight and you lose even 5 to 10% of your body weight, your psoriasis severity will likely improve. Your medications will work better. That is a fact supported by massive amounts of data. Because you're reducing the size of that inflammatory fat organ we talked about, you're turning down the volume on those pro-inflammatory signals.
What about supplements? Fish oil, omega-3, turmeric?
The data is weak or inconclusive. It probably won't hurt you, but it's not going to clear your skin like a biologic will. Think of it as a possible adjunct, not a primary treatment.
The text, being from the Malaysian Ministry of Health, addresses traditional Chinese medicine, or TCM, directly, because it's so culturally relevant there.
They do, and they're very careful. They note there is some evidence of effect for certain herbal preparations, but they also say the quality of the studies is generally low and there's a major safety concern.
Which is?
Adulteration. Some unregulated herbal products from overseas have been tested and found to contain undeclared heavy metals like arsenic or mercury or even hidden potent steroids.
So you think you're taking a natural herb.
And you're actually taking a powerful, unmonitored drug. You might feel great for a week, and then when you stop, you have a massive, dangerous rebound flare. The advice is, if you're going to use TCM, be transparent. Tell your dermatologist so they can monitor your liver and kidneys. Do not mix and match in secret.
Okay, we have covered a massive amount of ground. From the bad text messages of the immune system to sausage digits and laser-guided missiles, let's try to bring it all home.
If we summarize the whole thing, the message is really clear. Psoriasis is a serious, systemic, inflammatory disease. It is not just about skin. It is about your heart, your joints, your mood, and your overall health.
But it's manageable, and the treatment ladder is more like an elevator now. We have so many options for every level of severity. We aren't stuck with tar and messy creams anymore.
We have moved from a goal of simply managing the disease to a goal of achieving completely clear skin. The expectations have been raised, and for good reason.
So here's my provocative thought to end on then. With these super responders we talked about, the people who get treated with effective biologics early and clear up completely, do you think we're heading toward a future where we don't just treat psoriasis, but we effectively put it into long-term drug-free remission? Could we actually turn that faulty gene expression back off?
That is the $100 billion question. That is the holy grail of psoriasis research. The idea is that if we can intervene before that immune memory gets permanently etched into the system, perhaps we can reset it back to its normal state. We aren't there yet, but the data on early, aggressive intervention is pointing us in that direction. It's an incredibly exciting time to be in this field.
And for anyone listening who is suffering in silence, or maybe you're stuck using the same old cream that hasn't worked in 10 years, go see your dermatologist. The toolbox is full of amazing new tools.
Absolutely. Do not settle for suffering. Clear skin is a possibility.
That's it for this deep dive. Thanks for listening.